and asking the question, can an obese David slay the Goliath, which is atherosclerosis in America? And I think that this is something, a special population that we need to be concerned about. But what we have found is that not all patients with BMIs greater than 30 share the same cardiometabolic risk, and that certain biomarkers may help us to refine this assessment. So this goes beyond the metabolic syndrome criteria that we're familiar with, and it really looks at biomarkers in three buckets: glucose metabolism, adipokines, and inflammation, as affecting risk for really developing insulin resistance. So this is really, I guess, a degree of separation from cardiovascular risk, but it all, as you see, feeds into this. From the standpoint of glycated end products, the dyslipidemia that's characteristic of obesity and insulin resistance, hypertension, endothelial dysfunction with regards to adhesion molecules as well, impaired thrombolysis and inflammation itself, all feeding into atherosclerosis, but a degree of separation from this. And really framing it in terms of the new term instead of metabolic risk is cardiometabolic syndrome risk, encompassing all of these aspects that can be a significant part of obesity. But the question is, so if 25% of Americans are obese and 15% are going to become diabetic, 30 to 40% cardiometabolic risk, which ones are they? Which ones are at highest risk? And that's the idea here. There's such an enormous number of people that are obese. Which are the ones that we need to focus our attention on? And can we gain further insight with regards to biomarkers and sorting this out? So with regards to adipocytes, especially the visceral ones, pro-inflammatory endocrine effects are noted. A flowing of free fatty acid deposition into the liver, and in its advanced stage forming NASH, steatohepatitis, and so on, and distorting our lipid abnormality. And I think really of great interest of mine is the adipokines, leptin as a pro-inflammatory hormone, and also promoting resistance to insulin or insensitivity. And perhaps the most important one, adiponectin, in an inverse way. This is the one that is anti-inflammatory and is an insulin sensitizer. It sensitizes our tissues to insulin. And then, of course, the inflammatory markers that we're familiar with, and as well as plasminogen activator inhibitor, which is increased in obesity. So in terms of what we did at Biophysical was to try to sort out which are the biomarkers that seem to be most predictive of insulin resistance, and to put them together in a panel and to try to make it a reasonable price in the $100 range. And can be done as simply as a blood spot. That's how little amount of serum that it requires, and right now we're working on validation of a saliva test that would be very inexpensive for screening large populations. So some of the information basing the insulin resistance risk came from these two large studies, the Framingham Offspring Study, which is about 2,400 individuals, and then a huge study, the Women's Health Initiative, which were postmenopausal women, 82,000 of them, showing that independent of BMI, these were predictive of insulin resistance. So just some food for thought of trying to become a little bit more granular in our approach to those with obesity, trying to identify those that are at highest risk for developing cardiometabolic syndrome and diabetes. And of course, the major intervention here is lifestyle. It's weight loss. Now, it's easy to say and hard to do, but if the physician has some more compelling evidence of why this individual, we really need to lean on them to lose their weight, that for some it may be optional, it may be more of a cosmetic issue, but for you, because you have high risk, it's a mandatory thing that you lose weight. And one of the nice things about looking at biomarkers for determining risk is that you can also monitor that risk, that these change radically as people lose weight. So just an idea of something that we might want to consider as we approach this issue.
So this is a biomarker for monitoring individuals at risk of developing diabetes.
Right. First, it's a sort of a continuum of impaired glucose tolerance, and then insulin resistance, overt insulin resistance, and how that feeds into so many of the factors that we see in atherosclerosis, and then as sort of an end-stage diabetes.
Would there be a group here that you would do this test just by coronary calcium and say coronary calcium 0, you're fine? Can you find a group here that they're overweight, but because the biomarker result is great, you don't have to worry about your overweight?
Right. Well, I think it's one of those, as we get into that same argument with regards to cholesterol, what would you do with someone with a calcium score of 0, but they had an LDL of 200? What would you just sit on? And I think that I think that by looking at these biomarkers and stratifying their risk for developing insulin resistance and diabetes, I think that we can amp up our aggressiveness towards them. I mean, I think that some people are really on the verge of becoming diabetic and they desperately need to lose this weight. And so instead of just saying, hey, you need to lose weight as sort of a doorknob final comment as the doctor walks out of the exam room, to say, this is a serious issue for you, you need to lose weight, and here's how I think you want to approach it. Here's a strategy for it. And we're going to come back in 3 months or 6 months, and if you haven't lost that weight, we're going to have a serious talk about lap band.
So is this also potentially applicable to those who are not over 30 BMI, or they have excess body fat, like we call it normal obesity, normal weight obesity?
Exactly, and that's a great point. Is that what we have found in looking at over 2,000 people as sort of an observational issue is that there's definitely a correlation between low adiponectin and body mass index or waist circumference. But we do find individuals that are less than 25 BMI that have a low adiponectin. A lot of this is genetically determined, and many of these individuals have first-degree relatives that are diabetics, type 2 diabetics, and so on. And we refer to them as skinny fat people. It's a fat person hiding in a skinny person's body. But the point is that they are at tremendous risk for developing these issues. And along ethnic lines, Asians typically will develop insulin resistance at a much lower body mass index.
Any other questions?
So do you have these in relation to subclinical disease?
No, and that's what I was saying, is that it's one step away from that, because I mean, if you accept that there's a twofold increase in cardiovascular events if you have cardiometabolic syndrome or type 2 diabetes, and you want to keep people from reaching that stage, that there's some value there.
So as you know, this is as you said, a major effort, and with all these great markers, we got involved with this quite a while ago. We have a fairly large cohort of very high risk, insulin-resistant, obese Hispanic population. And a graduate student just finished her thesis, and she's been through the data, we're verifying it, and of interest for driving factor. Now, these are young kids. These are average age, 11 years old. The driving factor of everything is elevated, which absolutely shocked us. So, yeah, just one study, but we have two other very large cohorts of young kids, about 2,000 that are moving through the system of all ethnic, because this was highly specific to Hispanics moving through. But when you look at the literature, there's a lot of really inconclusive data. I mean, it all makes great biological sense, but it just the strongest thing we found, we did this in collaboration with UCLA and Cedars, in very high-risk families, again, Hispanics, was hereditary, it's clearly genetic, manifested through hypertension. So we didn't see the LD. And these are older kids, this is an offspring. So it's been highly disappointing so far.
Were you looking at adipokines and?
We have them all, and so far, that's why we're going through the data again. You know, graduate students are great, but they just want to be sure that we're just not finding LPL. That's all that stood out. It's not even that strong of a risk factor. It was the only thing that stood out to us. Don't understand it.
Yeah.
One more, just kind of related to this concept that, as Paolo presented yesterday, the coronary calcium scan has within it the pericardial fat.
That's right, I was going to.
And the pericardial fat is, we have an article that was in JACC Imaging a couple months ago, added to the calcium score in predicting future cardiac events. So it could be that we would want to have some kind of assessment of metabolic risk as part of the shape, and some of it could be gotten actually from the scan.
Yeah, I think we certainly will mention in the new shape 2 that you do coronary calcium from the very same CT scan. There are a number of other potential markers that could be obtained. The EAT index that Paulo said. As you know, I was behind this for years in 2003, and the critical observation was, I was talking to Dr. Cooley, who's a very famous surgeon. He said, son, in my years of coronary bypass, I yet to come and see one coronary plaque that doesn't have fat around. He said, every time I see bridges, there is no plaque in the bridge. And then I went to him, I showed him a very old Russian article that attributed pre-adventitial fat as a major contributor to plaque formation. In the early days, we communicated a lot of those. So one study we did, we injected super iron oxide, paramanganate iron oxide, USPIO, which are very tiny 10 to 15 nanometer particles, into blood in mice, and found them, a ton of them, around the plaque in the pre-adventitial fat, which were taken up by macrophage. And so we published 2 papers on those, and it is also in the shape book as well. Bottom line is, we went to Dan's center back in 2005. Is there any way we could collaborate and automate? Because that's the point, is that we'd be able to have it standardized. And it is now available. Now I've heard of 3 other software actually out there doing that. So it's definitely, it comes at no extra cost. You've already done coronary calcium. You got a calcium score, now you get fat score, and you can get aortic valve score, and so on. We'll certainly put that in there. The connection to, shape, as far as monitoring other metabolic markers, has to be seen in view of the monitoring, recurrent visits and so on. So once we summarize the findings and we outline the shape 2 guidelines for publication, we welcome your input to see where we can incorporate those.
So
So-
you make an important point, because, you know, the reason why, one of the reasons why is the world moved to imaging is because risk factors, with all the pathophysiology and everything we knew, just are very poor. There's never going to be a biomarker that's going to be exceptional. We can look forever. If it were there, we would have found it by now. But what's clear in the athro world, when you look across what's happening in humans, and you look down in animal studies, okay, our lab and many others have done a series of these, is exactly what you said, is that you know, you may not find, you know, adiponectin to be important as you know, blood, but when you start looking at the wall, you find incredible interactions with macrophages and T lymphocytes and whatever. And that's the mismatch that I think we have with biomarkers and atherosclerosis.
Yeah.
So it's very different. This is why looking at that end organ is really so important, because it's accumulated damage. Whether you really measure it in the blood or you take an action in the wall, it doesn't matter, because you're measuring the damage.
And while we're here and building practical guidelines here, there are others who are aggressively working on molecular imaging. They're trying to identify these markers in plaque. I'm aware of several, I've been consulting several. They're trying to identify vulnerable plaque and vulnerable patient-based disease, and those are really great hopes for us, because if one of those, two of those come out, identify people at very near future risk, then those will be our future additions to the guidelines. But as far as where we are now with the SHAPE 1 guideline, I'd like to summarize what we discussed yesterday, and Jeff is going to take notes. He will circulate that, and then we create the first draft, and just like we did earlier with the first one, you were the chairman, you're still the chairman of the editorial committee, is going to be a ton of emails. And nowadays, compared to 2004, today, we can have attachment more than 5-10 megabytes to our emails, and take it from there. So I want to start from the top, and Dan needs your help as you've taken this. So we've agreed to make a checklist that would be corresponding to Framingham 6% and higher. Now, Matt, do you want to put a cap on 6% and higher?
No, I think we should put the checklist and not go with the calculation.
No, we won't do the calculation, but we're writing the text of the
6%
guideline that
is
it
good.
would corresponding with the 6%. But
Right.
it would be a checklist. We also discussed with Tess team and David Spence being very pro to removing the cap because of the neurovascular events that we can prevent. So the idea was that we start from 40 and thank you. We start from 40 and we go up as high as possible. Is there any issue there to the cap of 75, because primarily neurovascular events are our target, would be our target for prevention. If we go over 75, but maybe should we go to 80? Should we go to what?
Are you going to cap risk at the upper end? So it's going to be 6 to 20, or is it going to be 6% and higher?
Well, our goal was 6% and higher, because even your high risk, current guideline puts you on treatment but does not deliver the severity of treatment to the severity of disease, because you could be a very high risk, which does not even exist in the existing guidelines. So,
Right, I would actually be taking 5 years off.
5 years off, so
So
5,
40, women 50.
yes, 40 and 50, and then
40 for women.
and then up 40 men, 50 women, and up maybe 80 for both.
I think 75 for men and 80 for women. I mean, you might
Yeah.
want to
Well, we
stack
have
it by
some-
5 as well.
You got, yeah, 75.
We have 75 currently for men, and that's what the issue was, that there are men who are 76-year-old and end up having stroke, and they have chronic plaque and they've never been recommended for screening. Perhaps, you know, we're pushing the envelope of life expectancy. Should we say 80 men and 85 women?
Can't they be presumed to be symptomatic at that point?
No, they're asymptomatic. They're purely asymptomatic, but they have giant black, never been screened.
They have very good genetics.
The upper limit can be the same.
Because 75 asymptomatic.
Oh, we have plenty there,
They have very good
asymptomatic,
genetics.
but they are walking time bomb. That's another way of putting it.
But more, you're lowering the age group at one end, you're raising it at the other end, you're expanding sheep. Right?
Yeah, that's what we're saying. We're gonna.
I just have to think about the implications of that, right? You got attacked because it was too broad, and now you're broadening it. So just something to think about.
Right. So
I don't think you want to broaden it.
We're thinking about it because we're saying that people after age 75, or maybe we could just leave 75 for male and 80 for female. Robert?
There's no difference in the older age group between men.
Yeah, they can,
There's no,
they
yeah.
can catch up. And then
Yeah,
they're
maybe
saying-
both would be 75 or both 80, Robert?
So you could justify moving the lower end if you initially had a criteria to screen them. So men under the age of 45 with an HDL under 40 or family history of a relative having a heart attack under 55. So to move the value down, I think you need to justify it, and that's not too difficult to do.
Well, we don't want to leave the cap open for less than 45. No, for less than 45 because we don't want to say you go and do coronary calcium for people, 35, because we know there's not much you can gain by having coronary calcium there. So we are going to have another set of guidelines that we discussed yesterday that would address the 20 to 40. The 20 to 40 will be less aggressive and not for identification of the vulnerable patient, but here is where we're looking at the vulnerable patient.
So if somebody criticizes this and says, why did you go from 45 to 40, what would your answer be?
That's a good question. So the question is that we have found based on the data, including recent publication, is that there is a significant risk there that would justify. I mean, you could always say 40, why not 39? I mean, you have,
So what I'm suggesting is that to decrease the level of criticism, you put in some softness in those recommendations. So below the age of between 40 and 45, we suggest this under physician discretion, something of that nature. For example, low HDL.
low issue. That's a good point.
Otherwise, people are going to jump all over that.
That's a good point.
On the other hand, one of the criticisms of Framingham has been that you're going to miss a substantial portion of people who, because age is so important, do not get the contribution from it when they're in their 40s, like women particularly. So you remove that barrier to being evaluated. You have to be 45 to be, as a man, and 55 as a woman to even get a Framingham score.
Well,
No, this is for.
but it's events. If you look at event rates that occur in premenopausal women, heart attacks and strokes combined, it's extremely rare. So there is always the Rose phenomenon that says that if you have a billion people and the risk is 0.0001%, it's still a lot of people having heart attacks and strokes. But we can't find that 0.0001%. We've got to draw the line somewhere.
Okay, how do you?
50 is not premenopausal.
50 is perimenopausal. That's about where
That's
you want to
about
start,
right.
right?
Yeah, they were.
We have to justify whatever we put in here. I just would like to be able to justify it.
I think we have a lot of trouble extending this at all. I think that we got a lot of criticism first time around, but now we're being shown right. Why don't we just improve what we have
Okay.
and say we were right? I think we could easily extend the 75 to 80. Nobody would even notice that.
Right.
But when you change the 45 and 55, that's going to be a big, big
Okay,
change.
let's do it. Let's
Do it as an
So
asterisk.
what about
As an asterisk saying that in some
Physician discretion.
younger
between
population.
40 and 45, and 45 and 55 in female, and 40, 45 in male, if you have so-and-so, you could consider
But also
screening.
we were shown some good data from two of, who showed that coronary calcium starts developing, the curves start diverging at age 45 in men and age 50 in women.
40 and 50. That was,
40.
And that was the
40
plaque.
and
That was
50.
carotid plaque as well. Diverse.
Right,
But
so we saw two slides. One was related to CT and one was related to carotid plaque. I think the ages were 50 for women, and I believe it was either 40 or 45 for men. So that would be the rationale for starting screening at that point.
Well, we have 45 currently. I think if we put this up, the asterisk, yeah, I think that's a good suggestion, and
Physician discretion.
Yeah, and to say, but give them an indication for that, because. And keep that in mind, the 20 to 40, we're going to cover in another guideline.
What's the percentage of women age 50 who have calcified flash? Do you remember offhand?
Somewhere around 25, 30%.
No, not that high.
For what?
Women age 50.
Have calcium, their average score, their mean score is 0, up to 75% is probably 0.
Right,
So
but
25%.
About
Any
25.
score at all. I don't know the exact, I can find it
I
right
think
now.
it was around 25.
I'll tell you in a few seconds.
That's a pretty big segment, though. 25% of 50-year-old.
But it's event, we're driving by events. We gotta have to be event driven here, not just calcium score driven, right? Because most of them are scores of 1.
So the issue is, should we separate the men and women by 5 years or by 10 years? Most of the epidemiology studies put them on 10 years.
So here's the distribution of women. What age are you? 46 to 50, 50 to 55?
50
Yeah.
to 55.
50 to 55, up to age 75% of scores are basically 0, and then you break a score of 10 with 20% of the population.
Yeah, that's 2025 is around 50. But I think what we have, if we put that asterisk between 50 and 55, or we could just say women between 45 and 55, that asterisk, and then define the criteria for
Yeah,
that.
I mean, you have a little 1 there. That 1 could say physician preference for younger participants based on risk factors and assess,
And
you know.
say the
Can
fact-
you-
and
can
make
you
a long
say-
list.
Can you say 45 to 55 depending on when their menopause occurs, like perimenopausal age, whenever that occurs?
Right. So I think that's a much better way, but I think that diverges from every guideline though. The problem is every other guideline is written with a hard age of women at 55. Even though that's not,
Yeah.
right, not all women that on their 55th birthday go through menopause, but that's just how.
But it
guidelines-
does match with the
Right.
distribution of calcium in men 10 years younger. So
Yeah.
that's how we came up with 45, 55. But I think that suggestion again with asterisks, and make this list and then leave it to the doctor to recommend. Okay, so top, let me count. So we would, from 75 go to 80, that doesn't hurt much. So just 75 to 80, and at that age, both are in the same risk. Because they're less
Exit at 80.
Yeah, exit at 80.
I think that's right. I was gonna notice
Yeah.
that.
Okay. Then we come down to the tests, as we all agreed, we're going to have 3 tests, and those all will be either coronary calcium or carotid INT or ABI, and if it's negative, you go to the second one. So if your ABI is negative, meaning it's normal, you do get, yes, yes.
If anybody's positive.
If it's positive, you are already high risk, then we're not recommending, coronary calcium.
Or, then, like you said yesterday, then everyone's going to just do the $12 API.
No, the question, if you do the $12 OBI, if it is normal, you have to do one of the 2.
But more, you are not suggesting doing API in a man 45 and woman of 55.
We were saying if it's abnormal, if it's abnormal.
Yeah, it's a poor screening tool. You cannot use API or recommend API in such young population. You must say in older, if you come to 60, you can use API as a useful screening tool. You cannot use API.
Their existing API screening age is 50. That's what they're using. Maybe we could just.
No, he's right. I mean, get that presence of risk factors, or you have to be about, a diabetic smoker.
Smoker or something like that.
Because the prevalence of abnormal ABI is very low in the general population, so you have to target it.
I thought yesterday we discussed that it was 4 to 7%.
But you need 2 more risk factors, and
Not in that young population.
so it's an average from age 40 to 90. If you take, then the prevalence is 5%. But it's very low, before a certain age.
Towards the lower.
Right, without any risk factors, and
Right.
it goes up with age and risk factors.
Right, so how would you put it here at the beginning, where a patient comes to the doctor's office, you would recommend them to do ABI, and if ABI is normal, they have to do the other two, you know?
It says if ABI is known to be high, the patient should be considered high risk.
High risk,
and no
right.
further testing necessary. So you're not recommending ABI, but if we already have a positive ABI, they're out of the algorithm.
Well,
Stop at that
From
point.
the standpoint of a guideline, I agree with, that it would be misleading to have an or ABI, and maybe, because it makes it sound like it's equally good at screening, and it's not as sensitive. And so maybe the way to do it is to leave it as an asterisk for the atherosclerosis test that, you know, in population 60 and above with 2 or 3 risk factors, it may be an alternative. But if it's negative, that you have to go on to one of these other more sensitive screening tools.
The PAD coalition and the working force already has those guidelines, so you don't want to reinvent.
We followed their guideline, that's what I said.
Yeah.
So we would just bring them up, we'll follow their guideline. This would be an opportunity to encourage the, you know, the peripheral arterial disease as part of the umbrella of cardiovascular risk screening.
But I think it shouldn't be an or, it should be an asterisk
Yeah,
or another
asterisk.
one of these numbers.
Yeah.
And it should say, in the older, in an older population, ABI might be.
Yeah, in the older population would be the population that PAD Coalition came up with.
Right.
So we don't generate a new guideline. We just replicate their guideline, but we acknowledge it as a screening tool. And if it's done, and if it's high risk according to that guideline, they don't need to go through this. They need to initiate treatment.
These are basically testing naive patients that we're talking about.
These are asymptomatic.
Right, who have not yet had any of these tests. And
That's
they're
right.
saying, these are our recommendations, these are the tests that you should have, rather than somebody who's already had the
That's
test
right.
and comes along and we plug them in here.
That's right. Those who were not previously tested are subject to this test, and that's how. Okay.
And we have our CACS, and then we also have ultrasound with
Carotid
two
screen.
options, CIMT, and then also the total plaque area.
Right.
There's 2 options of under the ultrasound.
Right, that is part of the ultrasound
Okay.
scan, and then and then CT scan.
Okay.
So we did have this discussion with PK, who did ultrasound, and it was normal. He would do coronary calcium with normal ultrasound, but the data that we got yesterday from Silicon Henry, it just tells you that a lot of people are going to have plaque. So do we need to say anything here that if you have a normal carotid IMT, you would need to go get coronary calcium, man?
Normal carotid IMT.
So you get normal, no plaque, normal IMT. Do we need to say that you would need to get coronary calcium?
More sensitivity. I mean, there's no doubt that just because one vessel doesn't have atherosclerosis, another doesn't. I mean, our data shows that, as I presented yesterday. But the other issue that I think is really important is we just had this long discussion about downstream costs.
Right.
So now if you say negative IMT, now you do a coronary.
That's a significant addition. We discussed that in shape 1, and we purposely removed it. Didn't recommend because it was too much of a burden. I'm just pounding here that
I'm not against it. I'm just saying that if you're worried about the cost, and then you start saying, well, this is negative,
That is-
negative, this, that now you're sort of in that quagmire, and maybe you'll be
yeah,
like Chris.
that's one side. On the
It's
other
an
side,
or. I would leave it as an or, and if either one of them are show low, then you're probably low risk. I mean, we have to trust the test that we're advocating without saying you automatically need the other, right? It's just.
right. Good point.
I
Or else
think
we're too wishy-washy. We're saying, well, we don't trust either test, so you need both.
PK does both.
Yeah, PK does but in Hollywood. That's different. It's
But he
just fine.
admitted yesterday that
Yeah.
But that's fine, and I think you can argue that both add value, but I think when we're talking about a national guideline, we
Absolutely.
gotta.
So if you look at-
Robert?
if you
Okay,
look
so
at-
the question is trying to steer them appropriately to an additional test they may not need. So the CIMT looks good, you're still concerned, you want to decide whether or not to get a CAC score. now you insert something else. You insert either, again, low HDL, 9p21, something like that that says, even though this person has a negative CIMT, there's a big high-risk thing sitting here that justifies the additional
We
test.
don't have data to back that up. Then we trigger another testing, and then if it comes to a unified universal guideline, we're going to be very limited there. But I think we have to keep that in mind as people are contributing to this thought, is that we also do need to consider cost effectiveness, and therefore, even though a test has value at large level, it may not turn out
Well,
cost
just
effective.
a lipid profile then, virtually
No,
everybody.
we have to, okay, the lipid profile, the checklist that we're creating, it's a checklist of blood markers and traditional risk factors. That if we need to have any specific in reference to any biomarker, because we can't make it a very extensive lipid profiling at the beginning. That would be too much. That would be just like we're recommending advanced lipid screening, and we know that's not really what atherosclerosis detection is about. Those are all risk factors, right?
I think we have to keep it as simple as possible, and even though if I had a patient with a normal carotid IMT, I would still feel much more comfortable getting a calcium score. I don't think we can do that.
You can do that as a guideline here.
Yeah.
No, but that is, I think, an important point. I showed you that the more than 75% IMT level was only reaching a number below 50%, 45%, I think, in our study, whereas positive calcium score was much more prevalent in the population. So you have a much higher prevalence of positive calcium score than positive IMT.
How many
And so
patients?
Plaque.
That was because you made it black.
No. It was, you remember, I can show you the figure again.
Yeah, I saw
It is, and we presented it 70, we published in the European Journal that really it was more than 75% IMT what we presented and what we measured. And clearly it's a difference. I would strongly oppose to mean that somebody can say, I do for the screening IMT, and when IMT is negative, then the patient is low risk.
You know, in our population, we had the other way around. We had very few people who had negative IMT but a positive.
Yeah, but have you done a population-based
This
study?
is a population.
Right.
This
That's
is a
not,
huge-
you cannot,
But also it
and we
depends-
are looking to a population which is not a patient, is subclinical atherosclerosis. And here the level of evidence is much different. It's much different.
What
And,
was
and
the
I
age
would,
group of your population?
45 to 75 years.
And what was the methodology of IMT? I'm sorry, was it?
Yeah, I can send it to you. It's all it's a semi-automatic. It's not automatic, semi-automatic. But it is published, the data are published, and you can read it. And it is something which many people observe, and I observe it since 15 years. I do calcium scoring. I do always intermediate signals. And I'm so much misled by normal IMT concerning calcium scoring. I, as a member, would strongly oppose to such a definition
Are you
that when you have a normal IMT, I don't need to do the test because much more patients, people will have positive calcium. You know, the number of positive calcium was, as you know, in men, 85%.
Well, I think
What was the finding in MESA?
As far as
The
positivity,
prevalence of carotid
overall, 40% had scores of 0. I don't, men more than women. I mean, men have more calcium than women. I don't know exactly, but instead of 80% prevalence, it was 60% prevalence.
See, because this
The
data
prevalence was
was
higher
not-
in recall.
Okay.
A little.
Of calcium?
Calcium score.
Yeah, 85% in men.
Right, ours was a little lower in Mesa. A little lower.
But also we have the data that somebody showed yesterday, you have plaque everywhere in 70% of patients. So to me, it appears that ultrasound is much more sensitive in detecting plaque. The question is what level of plaque is considered
Right.
abnormal.
But I just think we have to go with a test and leave it to the
I think so.
local
I
expert
agree.
to choose whichever test they're more comfortable with. Obviously, you're more comfortable with IMT because, you know, I mean, I'm just saying, but everyone's going to have their own thing. And I don't think we want to totally direct them to say you must do test 1. And if test 1 still doesn't show you anything, you must also do test 2. And if that doesn't show anything, you probably want to do test 3, maybe do an ABI just to make sure. I mean, if we're not comfortable with these tests, then.
And there are some
we would-
patients who, because of their neck anatomy, you really can't look at all the segments, and I think those patients are the ones you should get CAT.
Right,
I
but
don't
mean,
think it's
I'm-
enough to just see one segment and say IMT is normal, so, you know, post-radiation, post-surgery, whatever.
Well, I'm just saying, but I mean, I would be very comfortable if somebody had a CAC 0, if I'm thinking about their 5-year risk, I'm comfortable that their risk is low enough that I don't need to go on and do an IMT in that person. Now, maybe if they're 35 years old, that's totally different. That group is not in shape. So I don't think we need to go to the ABI maybe.
Well, I think we have the reality of cost effectiveness on one side, which pushed us to put 1 in. And remember, we're coming out from nowhere. There's no other organization recommending atherosclerosis detection screen-based screening. And we have, you know, this evolution of IMT plaque. I mean, this is a major study, 6,000 patients, showing that these many people have bilateral and unilateral. So there is a small population, just the green ones don't have plaque. Then we have an older, perhaps, methodology of IMT and plaque measurement, and there you only come the opposite. Your data says 70% didn't have normal IMT or plaque.
No.
So, yeah, so and different methodology would be one factor, but the cost effectiveness is very huge. On the other side, the liability or the pressure that you get somebody normal IMT and you want to let him go, you want to have enough confidence in the results. If this is the reality, then I'm not worried about it because I'm going to end up finding enough people with plaque and increased IMT. But if the reality is the kind of slides that
I think it depends on what protocol shape is going to recommend for IMT. If you're recommending one segment, the 75th centile in just one segment and one wall is not going to exclude atherosclerosis. But if you're recommending evaluation of all the segments, evaluation of plaque, then I think then carotid ultrasound is going to be very sensitive in picking up atherosclerosis.
Okay, maybe our approach would be we recommend just what we did in the first shade 1, but then put another asterisk here that if the screening is, if the result was normal and it was based on a relatively limited,
correct,
it was not comprehensive, either comprehensive is recommended or an additional testing. Or just given a little warning that if you don't do a good job of carotid scan, you're not going to get a good predictive value.
Just in the text somewhere, I think you can just mention
Yeah,
if the test is not comprehensive or diagnostically accurate, then consider another test, right? I mean, I don't think you need to put that in your chart. I mean, you want a very clean chart.
We're going to change the chart anyway.
Why don't we have an asterisk for every step? I mean, if we have every single thing as asterisks, then
we found in our study for the males, Einzigstoffbekost study, we find that 80.19% of the male have positive calcium score. And in IMT, more than 75% was found in 25% of the individuals. And as I showed you, positive ABI index was found in 4.7%. And when we go to the women, you see women have a calcium score of 55%. IMT was 25%. Yeah.
So first of all, you got the IMT here at 75%, whereas with shade, we put the IMT on 50th percentile. So if you get the 50th percentile, you right away change that significant, and you come to the coronary calcium level. Because look at this: if you take 50th percentile, you already got 25%, and you're showing 25. In your study, you're showing 25%. So it's almost the same. Add 25 to 24, You come to 50. 50 and 55, pretty much the same. So I think we're on the same page with taking the cut point. Okay, that's good to go.
But is 50th percentile accepted as a treatment threshold?
Yeah, well, basically we're saying that is the part of the population that you're trying
It's
to,
half the population,
yeah, take out from aggressive treatment.
only half.
So you're eliminating half the population up front, is I guess this intent,
No, no,
right? Less than 50.
Here is.
So by definition, you're
this
eliminating
one
half
is
the population.
50th percentile.
So I just want to ask a question, because this has confused me from the beginning. What's the percentile based on?
Based on we had Mesa or Eric study at the, are you talking about reference database?
Yeah.
Yeah, I think we've got Eric.
So those are very specific protocols, right? And if you're not doing those protocols, then that reference database doesn't apply to what you're doing. So it's unlikely you got clinicians out there following the Mesa protocol.
Well, I don't know what
But Eric
was
is the
similar.
firewall only.
Yeah, Eric was
And they
similar
did not
to Shape.
separate out the plaque, they just included plaque and iron.
Yeah, but again, and then the methodology of measuring is so different too.
Well,
Most of the systems that are employed out there now are automated.
Yeah,
Automated edge detection, and they're a mean over a distance, 1 centimeter, some go to
Yeah.
2 and 3. And ARIC was a single measure. What they did, they visually looked for the thickest part of the wall and then they measured it. But that's what Paul was mentioning earlier. One single measure, that's it. So it's a max.
I think
So
Eric
I just,
is-
as long as you're clear,
There are nomograms of Eric available in mean.
Eric has average and average.
But they didn't do the
Okay.
whole
Average
census.
max.
so where they, okay,
But it's
Yeah,
single on 12.
that's right. You gotta be really careful.
Single on
It's a
12.
mean max across exactly 12 seconds.
Right.
That's all it means. They measured once and then they averaged to 12 seconds, near firewall.
Right.
So you gotta be really careful. You know, I know everybody here probably doesn't want to hear it, but I think Matt verbalized this is exactly why Lauer and NHLBI aren't real enthused about IMT. Because they kind of know these issues.
Right.
It's
And we
very
know that
different.
too. We know that too, and that's why
Well,
we identify those as areas.
But the guidelines, but when you read the guidelines, they don't really say that. The guidelines make it appear that you can say,
No,
okay,
that's
I'm in
not-
my office, I do a measure.
No, that's-
Let's say I'm in my office, or just let's say I'm in my office, and I do a distal common cry firewall, one measure, and I do an automated measurement of that, okay? And now I'm gonna go to your guidelines and say 75%, I'm gonna use the ARIC.
Yeah.
Well, it's apples and oranges, they're
No,
completely different data sets.
Let me just, because you weren't there, let me just blow this. The guideline said, it had this asterisk number 4, pending the development of standard practice guidelines. That's what SHAPE is doing. We didn't just say, go do it. Because this was not adopted, we didn't push for that. And now we're at the stage that we will. We have the ability, we have a ton of progress made in this field. I think we are, and you're absolutely correct that we should here clearly describe it, and this is our challenge. This is not an easy job.
Again, I'm just pointing something out, whatever the committee decides to do, just be
But
clear.
keep that in mind.
That, you know, SHAPE is not the organization that's come out and made these statements. You gotta be really careful when you say, so the other thing that some of these methodologies have done is, you know, they'll look at a segment, and it doesn't matter really what this is, they electronically do this, and they'll do, 3 measures, and they'll average, go, okay, it's a mean average. Well, that's different than averaging over 1 to 200 pixels. Far different, okay? So you gotta be, really the percentiles only apply to the database of which you're following that protocol and how that database was developed. It's really just that simple.
That's right.
Which is why we also talked about this IMT training and IMT protocol, which SHAPE is going to.
Yes, that's what I said. The SHAPE.
But you don't have the database for that. You don't have the database for that. or that's the point.
Could we just use amount of plaque or something, or a certain thickness?
I'm not suggesting,
no, but can we
Matt, I'm not
better?
suggesting changing anything, I'm just
No, I think
pointing
it's
this
better.
out.
I don't understand this 50% anyway, because I don't see papers doing that. I see papers saying 0.9 is too much, or 1.0 is too much IMT. Can't we just make a set cut point like we have for calcium? Calcium is a set cut point.
No, for calcium
because
is
IMT increases with age.
Calcium percentiles we've already agreed are not good.
And that's the point too, is it all has to be age,
That's
and it really should
unequivocal.
be ethnic.
That's
It should also
unequivocal.
be
We're not
ethnic.
talking about calcium. Of course, we're using absolute numbers. Everybody knows that.
In every one
Everyone
of
knows
these
that.
categories.
Everyone knows that.
So what was the giant presentation that Paulo presented that is different in black, different in white, different in
And then his conclusion was a high calcium score is bad at any.
I know high calcium is bad, but what the amount?
No, we don't have, we publish that in Mesa, it doesn't help. Everyone in the calcium world agrees, that I know of, agrees very clearly, absolute scores are good enough, that's how we want to do it. Now, when it gets to younger people, less than 45, that's when the percentiles matter, but luckily, we're not there.
So Matt,
But anyway, that's a different argument. Let's use absolute numbers.
does calcium score not matter relative to age?
Right.
Really?
100 is bad
At any
age, and 0 is good at any age.
But is the risk?
The risk is much greater of 100 than a 75th percentile. So here's the problem we have. Alan Gersey did this, and he said 75th percent for his study. And the reason his study was 0.07 and not 0.04 was because he used a percentile. And he even wrote his paper, and he just used a simple calcium score cut point of 100, and he redid the math, it was 0.04. So he said percentiles killed his whole St. Francis trial. And since that time, we've gone away from percentiles. So, but that's a whole different argument.
Yeah,
Right
the
now, I
trial
would
is
suggest,
different.
no, the trial is pertinent, and Mesa, I did in Mesa, I said, which one's better? Percentiles with all the age and ethnic differences versus absolute, and absolute won by a lot.
So Matt, I think makes a really good point. And unfortunately, that's not how the IMT data has evolved. But if you look at the entire spectrum of IMT data for the last 20 years, there's almost one universality, regardless of methodology, study, and that's a 0.8.
Okay.
And almost everybody's data set, 0.8 seems to be that break point. But you're not going to be able to sell it.
Really?
It's gonna be very
Better
close.
than 50th percentile?
I'm not happy with because that's the reason why I said.
I'm saying, but I'll bet you the 6 people, the 6 experts in this room would come to a conclusion that a absolute number has got more validity.
You've done more of this than I have. You might.
I don't know, I don't know. You don't think, I thought IMT was people talk about a number being bad. I thought, well, 0.9 was
Professor
bad.
Cabal has large cohorts.
Well,
What do you say?
That was the case when the values, when the method was not really evolved. So
Okay.
they didn't want to look at the different methodology and took a number. But as far as the measurement is on the firewall, on the 10 millimeter length and well standardized with the measurement of the presence of the plaque.
Plaque
then-
separate.
Yeah, plaque separate.
Just IMT.
Oh, yes.
You were just saying IMT or plaque, so just leave
Absolutely.
plaque out for a moment. So,
Absolutely.
Plaque is itself.
plaque is itself.
And then it's normalized, and then you can have numbers.
Okay.
But these numbers, according to age and to gender,
Well,
and to
that-
sex, and to sex.
So here's the problem we have with calcium.
That's what.
We don't age adjust a cholesterol value, and we don't age adjust ABIs, and we don't age adjust blood pressures, right? 120 over 80 is normal.
That's true.
Not for 80-year-olds, for everybody. So calcium got a lot of bashing because they said you're the only people in the world who age adjust your value. Why do that? Where's the evidence for that? And we prove that that's wrong. So I'm suggesting, and I might be wrong because I don't know the IMT data very well, but it appears to me that age adjustment is incorrect and it's not based on anything.
But the problem
Any
with
science?
IMT is that it grows with age.
Yeah, we have
So
it.
the IMT that is good for a 45-year-old or that is bad for a 45-year-old may be excellent. The same IMT value will be excellent for an 80-year-old because here is the data from Eric. And you can see that this is black women, black men, white women, white men, and you can see that across the ages, the IMT is progressing 5th centile, 10th centile, 25th
But that's all right,
centile.
but what's the outcomes?
But the other reason I wanted to show you is that they have actually expressed their data from 5th centile to 95th centile, and obviously you can choose your cutoff to be 50th or 75th or 90th, and the higher you pick, the
No,
you know.
we did the same thing with calcium scores. I did the first paper, or maybe George Condos did the first paper on that, showing we have all these great 25,000, George had 35,000 patients with scores, age, gender, broken down, Hispanic, non-Hispanic, and we found out that an absolute number is bad. And maybe it might be simpler for the guideline to sell the number, 0.8.
But
0.8 or 0.9 is what I've seen people use as dividing, and I think 0.8 is something that is reached in an 80-year-old.
I'm saying we don't even know like, which number to
0.8 is
correlate.
normal, is the 50th centile
Right.
for an 80-year-old.
For an 80-year-old.
For an 80-year-old.
What's the setting fifth at his oldest age?
This is the Bogalusa study, just to show the ERIC, they used the means, and they reported their values in maximum IMTs, again from 25 to 40-year-olds, and they also reported in percentiles from 5 to 95, and you can choose your cutoff, abnormal cutoff, to be either 50 or 75 or 90.
But that doesn't mean it's a better way to
let's look
stratify
at
risk.
it. In a 45-year-old man, how do you see that? That would, 0.8 would come 75 percentile?
This is Bogalusa, they only enroll
they're
young
just
patients,
Bogalusa is
25
just
to
young,
40
yeah.
years old. I just wanted to show you the ranges of IMTs in this age group versus this one, which has 45 to 75-year-olds.
See, maybe it would be easy to pick a cutoff for the common carotid and then include the lesions, any presence of lesions.
Yeah, any
No,
lesion is
that-
already
Right.
is a-
And maybe then that gives the clinician the ability to then just go in and do the simple measure and then to look for plaques.
As soon as you find plaque, you
Because-
go.
Because one of the problems would be if you
I think
pick
if
an
you have
absolute
plaques,
number.
you're abnormal, you don't need to measure your IMT.
Yeah, well, you measure
Well,
IMT, but
But we need a certain amount of plaque if everyone has plaque. I mean,
You
everyone has
measure IMT. I think you should measure IMT, but when you have plaque, you're qualified for high risk. You're gonna go down that path. And I think your point is well taken. We should go back here and learn from chronic calcium lesson. I mean, he was a big
Well,
proponent
we gave a number here, we gave 1 millimeter, which is I think too high.
Yeah,
Yeah,
1
okay.
millimeter was too high. No, we
Right,
never.
no, but we have a number, and we have a 75th centile, we have both here if you look at it.
Okay, Tasneem, we did not put 1 millimeter for the initial skirt. The initial screening was not 1 millimeter, it was just 50th percentile.
Wait.
You see,
Here,
No,
so
it's just
CIMT
there's a 1
equal to
millimeter.
more than 1 millimeter or 75th centile.
Right, but.
or 50th
But Howard
percentile.
brings up a good point that
No, or-
there's not standardized percentiles, and if you choose Bogalusa, it's different than ERIC. If you choose ERIC, it's different than CHS. If you choose CHS,
But
it's
no,
different than
Matt,
MESA.
look at it, you're saying chronic, the CIMT more is 50th
Right,
percentile.
I'm saying do away with that. Call it 0.8, greater than or less than 0.8, or whatever the experts think the number should
Yeah.
be.
Okay.
I
I
mean,
think you have to define mean
Yeah,
or
this is
max, and you have
something-
to define which
yeah,
wall,
testing-
right?
But
This is
0.8 is abnormal for a 55-year-old woman. That's what I'm saying. A mean IMT of 0.8 is not good news for a 55-year-old.
That's where we're
Right,
going.
that's where we're gonna go with that.
Well,
We're
it
gonna say
might-
they're
but
bad.
That's abnormal.
0.75, let's say 0.75 is not good.
What's greater than or equal to.
So
But
it
he's
has to
saying,
be-
no, Tasneem,
What
you're
she's
separating,
saying-
no, you're separating out percentiles from you have to show me that's outcome data to back up what you're saying. I don't think there is.
No, she's
I think that's
saying-
your
No, there
perception.
is- no, there is
come
that.
on.
No, she's saying
This is scientific
0.75.
guidelines.
Okay,
This is not
guys,
a-
this is an issue
Where's
that
the
we have
data?
reference. And
Okay.
that's Mesa and Eric, we go to the database and we come back. Do you-
So just to
I have this
clarify,
here.
Matt showed us yesterday that between 1 and 10, we already know there's an increased risk with a calcium score. So if you can show that there's an increased risk at greater than 0.75 compared to 0.80, then you can have a justification for
That's
going down
right.
to 0.75.
So we're gonna have to go back to the database and we'll circulate it to come back. I think we
If you look
need.
at the event studies that have been done, that cut point appears to be 0.8. But you gotta go back in there and look at it more carefully.
Okay.
But we can
We
do
can
that.
do
That's
this.
easy.
So for right now, leave it at 0.8, you can modify.
Yeah.
But
we
please
can-
clarify, it's the mean IMT, not the maximum.
Okay, whatever we
That's very
choose.
important.
Yeah,
Whatever
the
we choose, we're gonna find out.
0.75 is good.
Yeah.
And
You think so
what
too, right? 'Cause
vascular
your
event?
data shows the same
Yeah.
thing.
All black.
Okay, so are we
Mean
going to
or
Plaque,
plaque,
combine?
plaque is
or
already
plaque.
taken.
Exactly.
Plaque is already taken, okay.
If you already take the plaque,
And
then should we
or.
just confine it to the far wall of CCA,
Yeah, I think that you have
Well,
the
right?
plaque.
That's, I think.
3 angles, far wall of CCA average.
I think to make it easy, you know, if you pick one segment,
Yeah.
you don't have to, I'm just saying. It makes it easier for the clinician.
I think we are.
Give them an absolute number, like Matt says, because like I'm telling you, use the percentile, it's like.
Everybody
an
here
alpha
kept
course.
saying it has to be simplified, it has to be easily
Exactly.
adoptable in primary care doctor's office. Therefore,
Exactly.
far wall, chloride IMT with those, whatever angles that we have, but plaque by itself qualifies you for high risk.
Okay,
No,
what if there is no plaque, the far wall of IMT is less than 0.8, far wall of CCA, but the near wall is 0.9?
A near wall, we're gonna have to rely on ASC's
No.
guideline. The near wall is hard to measure and rely on. There are so
Happens
many,
about 25% of the
so
time.
many.
Right, but our guidelines are gonna be simple, and you can go beyond that.
Testing, if you open your tool to a lot of credits, and you just kill it, I mean, then nobody will be
Yeah,
able
I
to.
agree.
because
I think you can leave it to the clinician's judgment.
I agree.
There is
If
no
they see a
judgment.
near
There is
wall
no
that's
judgment.
thicker than the far wall.
There is
they
no
just-
judgment for
Right,
it.
right.
There
You
is,
can't see it.
there's
But-
very good data. I'd have to listen to your rationale. But it's very good data. Vindalog published this. All the histological imaging data all consistently show that the near wall is highly variable.
Variable.
It has to do with the echo signal.
Right, echo signal.
Yeah, but how old is that study?
No, these are the histological studies are there's one more recent one.
but-
Now, Vindelhog's data is from, I think, 1994. It's a classic paper in the IMT field. And these are good arguments not to do IMT on the near wall. Lesions are different, obviously. And do this, you can do this in your lab. Just by varying the gain and the power, you can change that near wall much more than you can the far wall.
Let's
It just makes sense.
just stay simple and not.
So what worries me is in the clinician's hand. I mean, maybe in yours you don't have a problem, but I can tell you in the clinician's hands it's a big issue.
But I'll tell you that in Philips I-33, 10 megahertz probe, last 10 patients that I've scanned, acute MI, there's no question, less than 55 years old, 2 out of the 10 patients only had problem with the near wall of CCA.
So I think we can't go with your type of cases. But so what I'm saying is, you agreed last time that we should focus on far wall. ASC also
Right,
can
as long as we are doing plaque
Because
screen
we're-
everywhere
we're
else, we're
screening
into the
for
physician
plaque.
judgment.
You can overcome this problem with taking the mean of both sides, because you should not take the right or the left side, and we know that there is a difference between the right and the left side on the far wall, which is symmetric for near wall. So that's a way to get the mean,
There's one way to go. That's
to
a
get
good
the
one.
mean of the value.
Again, whatever we come up with, it will be after this meeting, simply through